Fish scale skin is the topic of today on this Derm Club podcast, better known as ichthyosis, which is a disorder of cornification characterized by persistently dry, thickened skin. Ichthyosis has at least 20 varieties, including inherited and acquired forms. Luckily today, we have Dr. Keith Choate, a physician scientist at Yale, who is an expert in ichthyosis. There are not many like him. At Yale, Dr. Choate is the director of research for dermatology. In his own laboratory, he studies rare, inherited, and mosaic skin disorders to identify novel genes responsible for epidermal differentiation and development. Through his research, he has developed one of the largest registries of kindreds with ichthyosis and have identified over 10 new genetic causes for this disorder. I am excited to have him as a guest on the Derm Club podcast to give us insight into the genetic workings of ichthyosis, how it is clinically diagnosed, as well as how it is treated. Welcome, Dr. Choate. Thank you for taking the time this morning to speak with us.
Terrific. Well, thank you so much for having me join you today.
So let's just start by reviewing the basics. For many of us who don't really know what ichthyosis is, can you share with us what is it? And, I understand it has to do with a poor skin barrier, but can you give us more details about what it is?
Sure. I think this is a conversation that I have with a lot of families at the moment that their child is born, because many kids with ichthyosis present at birth. And what's fascinating is they have a unified, often early presentation that diverges later in life. And so many infants who are born with ichthyosis, in particular, the recessive forms of ichthyosis, have something called a collodion membrane. Essentially, it looks like they're in a tight, shiny cellophane when they're born. That sheds, and then over time, their skin develops variable degrees of erythema or redness and scaling. Now, of course, there are other classes of ichthyosis as well, some that appear in the early stages of life, around 5 to 6 months of age. Those are typically in the erythrokeratoderma category. And there are also ichthyosis type disorders that feature blistering early in birth that can be confused with epidermolysis bullosa. In particular, this is known as epidermolytic ichthyosis and can present with widespread erosions. So dermatology is really important almost at the moment that these kids are born, because when they come out, the OB instantly says, wait, there's something wrong with this kid's skin. Pediatric dermatology, genetics and dermatology comes in. We now have the capacity, which is what's really extraordinary, to take people from having an abnormal skin finding to having a genetic diagnosis, often as quickly as within 24 hours at Yale and at many other institutions. And when we have a genetic answer, we can also give people an idea of what their overall prognosis is going to be in terms of what the child's skin is going to look like. Now, ichthyosis, by its nature, is, as you mentioned, a defect of the barrier. So all the genes that we know that bear mutations that cause ichthyosis, and there's more than 50 of them now, converge on barrier. And they converge on barrier in a variety of different ways. Some affect the synthesis of lipids that are necessary to create the sealing layer of the barrier. Some affect how the skin sheds. Some affect how the skin proliferates. Some affect how the cells actually sort of work structurally. And each and every one of those types of mutations, and there are myriad other classes of pathways that we could affect that would also have the same effect, ultimately converges us on this idea that the skin is supposed to hold water in. It's probably the most important organ in the body when you think about that. And when the skin can't hold water in, it has to compensate. And the way that it compensates is it just throws a whole bunch more cells on top of the mix to try to sort of create a workaround. And that's why many of these kids have a fair amount of scale, and the scale can have a variety of different configurations. And they have a varying degree of redness that goes along with it.
So, you said if the OB calls you in early enough, you can diagnose it pretty early on. And that obviously helps for the prognosis, but does it help for their future of dealing with the disease? Does it make it less likely to progress in a worse way, or does it just really give the family an understanding of what they're going to experience?
I think that you've hit on two really important things. So one is a lot of families with ichthyosis get misdiagnosed. And I hear about these cases, sadly, on almost a weekly basis from across the country and around the world. And that's simply because when children are born with skin disease and they're born in certain parts of the country, there isn't an expert in, genetic skin disease to be found. And so they are stuck with mystery. And I think that there is incredible value to families to be able to name the disorder that their child has and to actually connect them with other families that are going through the process of having a child with the same genetic skin disease that they do. And I think that, being a recent parent myself, uncertainty is the thing that really eats parents at night. And I think that being able to get a diagnosis helps. But there are, of course, a series of genetic causes of ichthyosis that are associated with potentially severe comorbidities. And so one of the cardinal examples of this is the erythrokeratoderma cardiomyopathy syndrome, which we identified in my laboratory. And this is due to mutations in desmoplakin. And children who are born with EKC syndrome, generally normal at birth, start to get red and scaly in the first few months of life. And they look for all the world as if they have congenital ichthyosiform erythroderma. But because they have a desmoplakin mutation, that mutation is acting on their heart as well. And they can develop a progressive and unfortunately lethal cardiomyopathy. And so being able to see the clinical clues that give you a sense that you have this particular genetic diagnosis, most obviously absence of eyebrows and nail deformity and potentially curly hair, is helpful. Getting a genetic diagnosis is helpful. But I think we're also coming to understand the pathogenesis of ichthyosis differently now. And one of the unique opportunities that I've had is to manage some of these children with EKC syndrome from very early in their life. And EKC is one of the immune activated ichthyoses. That is, the barrier defect leads to immune activation. We believe that the immune activation is part of what's contributing to cardiomyopathy. And so what we've been doing is we've been actually working hard to manage the commensal microbiota on these patients who are born with EKC syndrome early in their life to prevent progression to the more inflammatory phase of the disease. And in doing so, in our N of 3, we've seen no progression of cardiomyopathy. And so we are hopeful that if we are able to do expectant management of EKC syndrome, we might change children's outcomes. But I'll also say that for all children born with ichthyosis, particularly ones that are born with the collodion membrane, or children who are born with harlequin ichthyosis, which is one of the most severe forms of the disease, having early access to a team that's familiar with the management of the disease is going to make the family's experience better. It's going to make the child's outcome likely better in terms of the experience that they have.
Very helpful. Are there ways to detect in utero, maybe during the very last trimester, that your baby will probably have ichthyosis, either by doing an ultrasound to look at the heart to detect if there's any cardiomyopathy present?
So ultrasound has come so far. And so now with 3D ultrasound, you can get a fairly good image of what the baby's going to look like. And so it turns out that we are finding that many times patients who come to us have had a diagnosis that's been performed in utero via ultrasound. And they are noticing the ectropion, or the outturning of the eyelids that can happen, the eclavion, the outturning of the lips that can happen with a collodion membrane. But also they can even detect thickening of the skin that we would see in harlequin ichthyosis as well. And so those are actually some of the cases where we're in our best place, because then we can have the team in place when the child is born. So yes, I think, ultrasound and prenatal diagnosis is hopefully one of the ways of the future.
And to follow that, there's a big push to do genetic testing prior to having children. Is this something that you think could eventually eliminate the disease?
Yeah, so I'm also a human geneticist, as you mentioned, and we frequently encounter this question. I think if you know that a disease has ever appeared within your family, it probably makes sense to do genetic testing and to ensure that your partner is not a carrier for that mutation. Genetic testing overall, I mean, it's interesting. It's becoming less expensive, and so I think that perhaps modern couples may get exome sequencing, look for rare variants, and be able to get a sense of whether there would be a possibility. And obviously, genetics is not destiny necessarily. That ultimately they could have a child who has a genetic disease, including a genetic skin disease. This is being done more routinely for certain populations who are enriched for genetic disease, but certainly one could imagine that it could be on the horizon for the general population in the near future.
I'm just curious, if someone was thinking of conceiving, that they might be encouraged by their OB or gynecologist early on, or even their primary care doctor, to, before conceiving, go get genetic testing, because it could obviously eliminate many diseases from occurring. If you have a patient who has if you have a family who has a patient that has ichthyosis and they are interested in having another child, how do you educate them and how do you guide them through that?
Well, I think this is one of the special things that we're able to do with the Ichthyosis registry. So over 10 years ago, we partnered with the Foundation for Ichthyosis and Related Skin Types to create a registry of patients and families with disorders of cornification and keratinization. And so we just recently published an article on the analysis of the first 1,000 families that we have had come through this. And we've actually been able to provide a genetic diagnosis to over 900 families for free via the Ichthyosis registry. And in many cases, individuals within the registry have decided to have children. And we counsel them on whether they have a recessive disease or they have a dominant disease. Obviously more difficult to pass on a recessive disease unless your partner has a mutation in the same gene. But with a dominant disease, you're dealing typically with 50-50 risk of transmission. Our standard issue has been to connect these families with certified genetic counselors who can talk with them about the risk of having an infant with ichthyosis, and also on how they might be able to engage in something called pre-implantation genetic diagnosis, where fertilized embryos, a single cell, is actually analyzed for presence of the mutation. And then only embryos that don't have a mutation are reimplanted into the mother for the purposes of conception. So there are options for families now, and we've had many, many, many families that have actually gone on to pursue this. We want to provide them with the data and the knowledge that they can use with their providers.
Can you explain more about the pathophysiology of ichthyosis? I know there are many varieties, so does each variety have a different pathophysiology? And how many genes at this point do we know about that can cause ichthyosis?
Yeah, the pathophysiology of ichthyosis is incredibly complicated. And I think that it really depends upon the specific gene that's mutated. And there are convergences that we see. As I mentioned earlier, essentially every mutation that we see, whether it's in a tight junction protein, or it's in a DNA repair protein, or it's in a structural protein, or it's involved in lipid biosynthesis, converges on barrier dysfunction. And it can do this in a variety of different ways. It can mess up the scaffold that the lipid barrier is placed upon. It can leave components out of the barrier. It can cause aberrant gene expression profiles. It can cause cell stress. I think there's probably decades of work left to be done to truly understand the pathogenesis of ichthyosis. And certainly many are working on this now. Numbers of genes, it's probably 60 plus. How many are left to be found? Probably 20 or 30 more to be found. And certainly, you know, one of the things that we do is, you know, we essentially believe that humans are the best genetic model system, and that everyone out there in the population, with our population of now 7 billion, provides an opportunity for us to find a rare genetic event. And so it turns out that people send me emails and Facebook messages and Insta messages and Twitter messages from all over the world with their unsolved cases. And our answer to these individuals is always yes. It's, you know, find a way to get us some DNA, we'll get it into the lab, and we will do our best to try to get you an answer. And it has been truly remarkable for me to have the power in the laboratory to leverage genetic tools and cell biological tools and biochemistry to really dig into these, to figure out new genetic causes of ichthyosis, and to really unravel what is a tapestry of biology that underlies epidermal differentiation, proliferation, and all of these pathways that are really ultimately relevant to us having normal skin or to having the abnormal skin of ichthyosis.
How do you go about diagnosing it? Obviously, if a child is just born and they have a colloidal membrane, that's probably a big giveaway. But there are cases of ichthyosis that do not either come later in life or don't have that membrane. So do you ever find that you need to do a biopsy, or just really by clinical features you know that this is ichthyosis?
Clinical features are really important. And so I frequently have fellows that work in my laboratory. And at the end of each week, we do something that we call running the books. We have these giant binders in which we keep photographs of patients, their clinical intake forms, and all of the stuff that's related to the registry. And we essentially look at our genetic findings and we look at the photographs. And every fellow who's come to the lab has said that by the end of the year, they feel like they can see genotypes when they're walking down the street. They can see someone who has ichthyosis and know what they have. And so I do think that clinical findings are super important still. And this is funny for me to say this because I'm a human geneticist, and I should say, just do the genetics and you'll get the answer. But, you know, as physicians, our most powerful tool is clinical examination. And there are frequently subtle hints to genetic diagnosis. There are also cases that are unusual, that haven't read the textbook. And you think to yourself, well, gosh, this probably is a type of ichthyosis. Let's let genetics lead the way. You asked the question of biopsy. Biopsy is super helpful. And biopsy is super helpful in a couple of different ways. So one is when a child has ichthyosis, frequently everything else they have gets blamed on their ichthyosis. And so I have had kids come from around the world and across the country to my office who have ichthyosis, but they also have findings of psoriasis or eczema. And so if I see something looks like psoriasis or eczema, I'll biopsy it and say, hey guys, this is psoriasis or eczema. There's really great treatments for that. And remarkably, no one's thought about it. You diagnose it, you treat the other disease for which having ichthyosis can sometimes be a predisposing factor, and they get better. Biopsies in ichthyosis itself are diagnostic in only a fraction of cases. So some cases of ichthyosis vulgaris will show a reduction of the granular layer. Epidermolytic ichthyosis, also known as epidermolytic hyperkeratosis, does also have some diagnostic findings. And this is one of the reasons that I tell my residents in dermatology that when they face a baby with blisters, we want to think about a variety of causes, including infectious causes as well as genetic causes. And while the first thought one might have is epidermolysis bullosa, one must also keep the possibility of EI in mind. And there is a characteristic histology for that. So that's one of the instances where skin biopsy is helpful. But for 90% of patients presenting to an ichthyosis clinic, a biopsy is going to show, acanthosis, hyperkeratosis, and possibly a bit of hypergranulosis, features nonspecific, potentially consistent with ichthyosis. So maybe, good to have down the road, but I don't think terribly diagnostic.
What are the associated diseases and risk factors that you often find with your patients?
So associated findings can be pretty variable. And so this is why we really do move to get to a genetic diagnosis for our patients early on. So we know that their risks will be associated with the type of disease. So Ichthyosis vulgaris is the easiest, asthma, allergies, atopic dermatitis. So those are the things that we'll see with vulgaris, and vulgaris is common. So that's the thing that people are going to see most commonly in clinical practice. X-linked ichthyosis, another common type of ichthyosis, is primarily due to de novo deletions on the X chromosome. And these deletions can be tiny, and they can take out just STS, which is the gene that's responsible for X-linked ichthyosis. But as those deletions get bigger and bigger, they take out more and more genes. And depending upon the function of those genes, you can see significant intellectual delay, you can see immune deficiency. There's a variety of other things that can be associated. But your question is probably more about, what about this normal kid that I see walking into the office who's got scaly skin and redness? And those kids will be variable. So, commonly we see individuals who have a lot of scale having a lot of itch, and the itch can be from the scale itself, because the scale is essentially sort of poking them in various spots, and so descaling them can be helpful. We have a variety of ways that we can do that. It can be because their immune system has been activated. In the case of the immune activated disorders, individuals with ichthyosis are at increased risk for fungal infections. So we can have candida infections, we can have tinea infections, which are driving their itch, that are completely undiagnosed, and you need to do classical things like scrape them and see that they have hyphae on clinical exam. But we also can see children who walk in and they have findings that can be seen directly. They have gait abnormalities, they have nystagmus. And that tells us frequently that we have a syndromic ichthyosis, and syndromic ichthyoses can be associated with eye abnormalities, ear abnormalities, liver abnormalities, gait abnormalities, brain abnormalities, neurologic abnormalities. And so really, our goal when we're doing an initial visit with an individual who has ichthyosis is to really sort of get a sense of their history from the moment they were born to the moment that they're presenting with us today. To do a full review of systems, to find out about the developmental milestones for children, and then to really, provide advice about further workup that's based on whether we believe that this is solely a skin disease, or if in fact it is a syndromic disease overall.
Is it the genetics or is it the clinical features that help differentiate which type of ichthyosis they have? There's so many types: lamellar ichthyosis, ichthyosis vulgaris, which you mentioned, Harlequin type. I also read about a type called confetti. So how do you differentiate between these varieties?
Well, it really depends on when we're seeing the individual. So, some are obvious, some are subtle. And I think that, does it matter if we differentiate them? I'll say maybe, because we don't have perfect pathogenesis-based treatments for most of these disorders. We and others have shown that there are certain ichthyoses that respond particularly well to systemic therapies. So, for example, KDSR mutations that cause progressive symmetric erythrokeratoderma are exquisitely sensitive to isotretinoin because it induces salvage synthesis of ceramides, which aren't produced by patients with mutations in that pathway. We and others have seen that treating patients who have EKC syndrome with ustekinumab can lead to dramatic improvement in their skin. And so overall, I think clinical features are what help us to come to a diagnosis, but we always pursue genetics because sometimes genetics can reveal to us risks that were not initially appreciated. Genetics can also help us to get some sense of prognosis because there are a variety of different types of mutations that can happen in a single gene. And these can really run the gamut from complete loss of function to minor changes in function. And so the genetics can tell us whether we're dealing with a loss of function or a change of function state. It can help us to give people some information about prognosis, particularly if we're seeing a child early in their life. You mentioned ichthyosis with confetti. IWC is hard to diagnose before there's a white spot or a confetti spot. And so, I have encountered a lot of these kids on, giving a grand rounds at another institution, and I see they have some subtle features of the disease. They haven't yet got a white spot. They're carrying a genetic diagnosis, which is wrong. And I'll come back to that in a moment. Ultimately they have confetti. And so what do I mean by a genetic diagnosis that's wrong? So when we do genetic testing in ichthyosis and for many things, what we get is a report. And that report says either your patient has 2 conclusive mutations in a gene that causes recessive disease or 1 conclusive mutation in a gene that causes dominant disease. But sometimes we get reports back that say your patient has a single heterozygous mutation in a compelling gene for ichthyosis. That's not an answer if it's a recessive disease mutation. And yet people frequently decide that it is an answer. Like, oh, we just couldn't find the other mutation. Those are the patients that need to go to a research laboratory because frequently patients who have a completely different genetic disorder can have another passenger mutation in a gene that causes ichthyosis. And so I've seen that happen dozens and dozens of times now as we've been working with the registry. So it's important for us as dermatologists to really know what the power of genetics is. When the answer is clearly yes, you've got a yes. But when it's oh, well, we see 1 VUS and 1 mutation, that's when we really need to engage with research programs to try to make sure that we're getting people all the way there.
It sounds like there could often be a delay in the diagnosis because it's difficult to diagnose, and which is upsetting because, patients could live with this for a long time and not know that they have or be searching for the right answer.
I think you're absolutely right about that.
And hopefully, because of you, we will have a better future of diagnosing it, but I think that would require more people like you to come into play. So, I've read about that many patients, because of their poor skin barrier, have a very hard time. They can't sweat, so they can't go to warm climates, and patients were saying that they can't even go to the beach. What do you advise patients who live in warm climates and they can't help it? That's where they were born, that's where their family lives, and they have to deal with it. Is there any suggestions you give them besides move to a colder climate?
It's interesting. It sort of goes both ways because often warmer areas are also more humid areas, and having greater humidity can be very helpful. So I've had people with Ichthyosis vulgaris or X-linked ichthyosis who moved to Georgia and they say, oh, my ichthyosis is gone, which is great. But you're highlighting one of the things that's very difficult for patients and families, and that is, not being able to sweat can be a limiting factor for children and for adults who want to engage in normal activities like playing sports. And so we have some simple physical measures that we can use. It turns out that a spray bottle of water is super helpful. So when parents see that their kid is getting extra red and a little bit slow, come on over, they hose them down with a spray bottle of water and they're good to go. They wear a wet t-shirt. They wear a cooling vest. There are rapid cooling mechanisms that people can grip. And so these are all sort of physical measures that we can use. What's interesting is the sweat glands are actually still present in patients who have ichthyosis. They're just occluded. So the way that deodorant works is it occludes sweat glands. So in this case, we have scale that's occluding sweat glands. And so one of the other ways that we can treat hypohidrosis is to treat patients who are appropriate with an oral retinoid like isotretinoin or acitretin. And what those drugs do is, via a variety of mechanisms, they lead to shedding of that excess scale. When the excess scale is shed, it allows people frequently to sweat. And in fact, I have a really wonderful story of a patient who came to me in her 40s because her daughter said, "Mom, it's time for you to deal with your scaly skin." And she'd never really thought about it. You know, very well adjusted, had a great family, good job. But it was her teenage daughter who said, "You got to deal with this," right? And so she comes in, very sweet. We start to, work on it. And, and I said to her, I said, "What would you think about getting rid of your scale?" She's like, "Ah, really?" It's like, "Yeah, let's do it." So we put her on a relatively low dose of isotretinoin, and she came back a month later and she said, "Oh my God, sweating is so gross," right? And so she developed the capacity to sweat. But it also made her really happy because now she was able to go to the gym and do a variety of other things that she had thought were off limits for her. And so, we frequently don't recognize the gifts that have been given to us until they're restored. And so, I think isotretinoin, acitretin, really helpful for helping with the hyperhidrosis. People can also do long tub soaks, and that can help them to really descale. In particular, if we add bicarbonate to the bath, that actually activates natural proteases within the skin to enable scale to shed. And so a combination of descaling in a bath, using oral or topical retinoids can help people to shed some of that scale and ultimately to sweat.
It reminds me of bleach baths, which we often tell atopic dermatitis patients to use.
And bleach baths have a role in ichthyosis as well. One of the other things that people complain about when they have ichthyosis is that their skin has a very sweet odor. And it's not unlike if you ever had a cast and they take off the cast and there's an odor to the skin. That's the odor of retention hyperkeratosis. Essentially, bacteria live within hyperkeratosis, and it contributes an odor. If we have patients do bleach bicarbonate baths, that odor essentially disappears. And that's also one of the things that I think can help to improve their quality of life. And so bleach baths are useful for so many reasons that we're beginning to understand scientifically, but also practically. I think they have real utility for patients with eczema and also with ichthyosis.
It just takes some explaining when you tell the mother or father to put their child in the bleach bath. They look at you cross-eyed.
I try to make it an analogy to a spa. I say, all right, it's about the amount of bleach that you actually have in a hot tub.
So, does ichthyosis, I understand it causes problems with the sweating. Can it also cause problems with itch? And is this something that using isotretinoin can also treat?
So itch is highly associated with ichthyosis. It's more associated with specific forms of ichthyosis, specific genetic forms of ichthyosis. So Netherton's syndrome, for example. We are coming to understand that commensal bacteria and often pathogenic bacteria can contribute to that itch. So staph in particular can drive itch. And so, treating patients for staph is an important part of treating their itch. I mentioned before, concomitant tinea infection can drive itch. So we want to make sure we're looking for tinea. But there are also fundamental aspects of the genetic disease that contribute to itch. And this is among the most frustrating of the conditions that patients with ichthyosis have. And it's one of the areas for which we need to have better treatments. There are a number of off-label approaches to treating the itch of ichthyosis, for which I hope will ultimately have results in the future.
Do you find that patients are, I guess, like psychologically frustrated by their disease, and the only thing that helps them is the community of other ichthyosis patients?
So while I am primarily a basic human geneticist, one of the beautiful things about working with the Foundation for Ichthyosis and related skin types and meeting these families over the years and having had a number of really, truly wonderful fellows that have come to my lab to work on the sort of clinical correlates of the genetic studies that we're doing is we've had a chance to actually begin to answer some of these questions. And so we actually did a fairly large study of mental health and ichthyosis, and we found that there are significantly higher rates of depression and anxiety, both in children and adults with ichthyosis. We also found that there's a significant impact on family quality of life. And you can see why this is. Ichthyosis is by nature a disease that you can't hide. You have congenital heart disease, you can go to a cocktail party and no one's going to know that your heart is working at 15% of its capacity if you're not turning blue, right? You have ichthyosis, everyone sees it when you walk into the room. And, patients have told me that they face significant social consequences. They are at the food store and another parent scolds the parent and says, you really shouldn't let your child lay in the sun so much because they have severe erythema. But then there's also just the sort of sense of self that I think is affected by being different. And these are things that can drive mental health issues in patients who have all kinds of skin disease. I think they're particularly prevalent in ichthyosis, and I think that we as providers need to ensure that we are using some of the standardized screening tools for mental health issues in our patients to identify them early and to really connect them with resources that are about building their sense of self, building their sense of community. And there are a variety of mental health providers that we've worked with that have been wonderful. Now, one of the other things that I will say is I have been incredibly blessed to work with this community because I have seen that kids with ichthyosis should literally be the mayors of their towns because they are these outgoing, friendly, beautiful, warm, welcoming kids. And I think that this is not genetically determined, but when you have something that makes people come to you to comment on your skin disease, it naturally turns you into a bit of an extrovert. And so we have a talent show at the Foundation for Ichthyosis, and it always warms my heart to see these kids out dancing and singing and really showing off all of their unique talents and skills. And so, I think we need to recognize that even that child who's dancing can be having issues with mental health, and we should be addressing that as providers who seek to really treat the whole patient. But overall, as I say to every parent that I meet who has a child with ichthyosis, this is a disease which will change the soap that you buy for your laundry machine. It will change how you bathe your child. It'll mean you're going to need to buy a bunch of moisturizers. But it doesn't mean that they won't be the lead in the drama club, that they won't be the captain of the basketball team, or that they won't have a family and an extraordinarily full life. Because I think that's a very important message for people to hear early in life and repeatedly throughout their life. And it becomes something that's easier and easier to believe as you see this child growing and thriving despite having skin disease.
Thank you for sharing that. You mentioned that patients with ichthyosis are at risk for more bacterial infections or fungal infections. Do you have any concern that they can develop a resistance to antibiotics or antifungals that they're using to treat their skin for these bacterial infections? If they're having multiple staph infections throughout life and you have to put them on antibiotics pretty frequently, it can, I'm sure, become a little bit concerning.
Sure. Resistance is always an issue. It's the issue that we face whenever we're dealing with patients who have recurrent infection. And that's why the first thing I say when someone's having a flare of itch is, come on in, we want to swab you, right? And then look at sensitivities and if there's staph present to treat it. If we have an apparent tinea infection that's not responding, we consider biopsy, we do culture, move for resistance as well. I think you've highlighted an important clinical point.
What are the treatment options that we have out there? I know you mentioned topical isotretinoin and baths. What other options are there for patients?
So topical isotretinoin is in clinical trials right now, not currently available in clinical practice. But we do have topical retinoids. The primary one that people use is tazarotene. Some people use classical tretinoin as well. So topical retinoids are one option. To stay in the topical class of therapy, emollients are another option. Emollients generally apply lipids to the surface of the skin to help with water loss. But of course, we recognize that there are emollients that have a variety of other agents contained within them that can be helpful. So humectants are helpful, like urea. They help to draw water into the skin and prevent fissuring. Those are particularly useful for the palms and soles. Glycolic acid and lactic acid as additives to moisturizers can be helpful for decreasing scale and increasing hydration of the skin as well. So there's topical class of therapy. There are many people who mix up different products. They have glycerol, glycerin, and polyethylene glycol, and a variety of other things that can help. But that's probably beyond the scope of what we're talking about here. We want to do targeted therapy for obvious infections, bacterial and fungal. And finally, we have systemic retinoids. And systemic retinoids include isotretinoin and acitretin. In general, we use isotretinoin given its flexibility of dosing, and particularly in female patients who may wish to become pregnant in the future. This is a shorter washout period than acitretin. Acitretin, however, can also be highly efficacious, and we use it in selected cases, assuming that we have appropriate understanding from patients regarding pregnancy timing.
What's the future for ichthyosis? I mentioned topical isotretinoin, which is in clinical trials right now, which I'm sure is a very exciting option because you don't have that systemic absorption or as much systemic absorption if you're applying it topically. Can you tell us a little bit more about this clinical trial and if you're doing any other clinical trials right now with other treatment options?
So this is a really exciting period for rare disease because companies across the country and around the world have actually recognized that there is a business plan centered on treating a rare disease. Unfortunately, it also means that they're probably going to charge a heck of a lot of money for the treatment that they've come up with. And so, I see as one of my jobs running the registry to talk with these companies as they're bringing things forward. And so while I can't give specifics of things that are not yet in clinical trials, what I can say is it's really wonderful to see how people are bringing to bear cell-based therapies, genetic-based therapies, structural design of potential systemic therapies that target individual genes, as well as things like new topical retinoids, topical isotretinoin, for example, to clinical practice. And so I think that science will ultimately lead the way. And the question is it going to be via gene therapy or is it going to be via a different type of therapy? And when people ask me this question, I frequently talk about high cholesterol. High cholesterol is one of the most common genetic diseases in the population. And yet, do we do gene therapy for high cholesterol? No. We have a highly efficacious small molecule that intervenes upon the pathway. I really hope that we'll be able to identify via genetic investigation, via all of the technologies that we have at our fingertips now, single common pathways that drive the pathogenesis of ichthyosis that can ultimately be targeted with small molecules, much in the way that we use statins to treat high cholesterol. And so, I think that for individuals who have ichthyosis, the most important thing is for them to enroll in the registry, even if they already have a genetic diagnosis, because one of our goals is to connect patients with a genetic disorder to a clinical trial that's matched to their genetic disorder. So we hope to essentially serve as a matchmaker for every new clinical trial that comes out in the future. And so, to answer your question succinctly, I think the future is bright. To answer the parents who are looking for disease today, I understand how hard it is to be waiting, but I think that good things are coming.
Thank you. Before we wrap up, I would love for you to share with me and the audience what led you to pursue a specialty in ichthyosis.
It's an interesting question, and there are probably many different ways and a long, complicated story that I could tell. But essentially, what I'll say is this: I grew up in a small town. My mom was a teacher, my dad was an engineer, and I always admired the doctors who were at the church that I went to, and I figured that I would be a primary care doctor with a white picket fence. Family moved to California. I ended up going to Stanford. I still had this sort of nebulous idea that I was going to be a primary care doctor. I ended up, taking hardcore science classes in giant lecture halls, and it was sort of a grind, as pre-med is, as many of you know. But I really didn't have any sense of what research was. I was doing a work study for actually a priest who said, "Oh, you want to go to med school? You really should talk to this guy that I'm marrying who's a cardiologist." And so I met with a cardiologist, and he said to me, "Dude, you're never going to get into med school if you don't do some research." I was like, "What do you mean? What's research?" Because I came from a small town. So he said, "Well, you've got to go to a laboratory and pick up a pipette and do some stuff." And so I went on the undergraduate research database. I found a high-powered cell biology lab at Stanford, started working for them. And they told me that I had to make solutions for them for 2 years before I'd be allowed to do anything meaningful. I was a freshman. It really was terrible. It was just awful. And so I looked at the undergrad research database as I was filling the carboys for this lab, and I saw an ad for a brand new faculty member who was starting his laboratory. This was Paul Kavari, who's now the chair at Stanford. And I went over to Paul's office and I sat down with him. And it's amazing. And many of you who've met Paul will understand this. In a very short conversation, he told me that we wanted to do targeted dimerization of receptors to heal wounds, which ultimately ended up being science that didn't work. But in the course of the conversation, and Paul was someone who really had an infectious enthusiasm for science, he said, "Have you ever thought about doing MD PhD?" I was like, "I have no idea what that is." Anyway, Paul hired me. And about a year into my work there, he said, "Someone just identified the genetic basis of lamellar ichthyosis. And I've got a friend who can make these retroviruses. We should see if we can cure ichthyosis." And so I used to get in my car and drive from Stanford up to UCSF to meet with Mary Williams, who had the premier ichthyosis clinic in the world. And I was 20 years old at this time, to do biopsies, to get cells for us to do genetic correction with the retrovirus. And I remember a couple of things. So one was the interactions that Mary Williams had with her patients with ichthyosis were extraordinarily profound. And I was a young and impressionable undergraduate who was really struck with how severely affected these patients were. Then I went back to the lab and we used our retrovirus and we used to do this radioactive assay for transplant. And what I discovered is, when we introduced this retrovirus to cells from patients with lamellar ichthyosis, we completely corrected the biochemical abnormality. And then we grafted those cells using split thickness skin grafts onto mice, and actually cured the disease. And so this was the first ex vivo gene therapy for genetic skin disease. And it's actually the basis of Stanford's company Abeona, which is treating EB. And so there were many things that happened in the course of that period in my life. It was exposures to mentors who told me about the possibilities in the world. It was the thrill of doing science that actually was meaningful to patients. And it was understanding that genetic skin disease can profoundly and deeply affect the patients who have it. And I think that, that was the moment. It was sort of an epiphany for me, that this would likely be what I would do. And, I would stray away and work in, cardiovascular and renal genetics to get good training in the field of genetics. And I thought about hematology and oncology, but when it came time for me to really sort of put my nickel down and think about what sort of a physician scientist I wanted to be, I came back to ichthyosis. And I am so glad that I did, because I think over the last 15 years, we've been able to discover a lot of things that ultimately will be important for changing the face of ichthyosis and potentially other diseases.
Thank you for sharing your story with us and for impacting the ichthyosis community in a very positive way. I'm hopeful for the future because you're really leading the way for us. Before we wrap up, are there any other questions or comments that you feel like we didn't touch upon today?
No, I think that I really have enjoyed having the opportunity to speak with you. For those patients who are looking at your podcast, I hope that they will seek out the Foundation for Ichthyosis and Related Skin Types, which can provide them with wonderful support and can also connect them with our registry if they're not yet enrolled.
Thank you, Dr. Choate.
Thank you.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.